we talked a lot about the clinical setting, right?
Yeah,
And we got to talk a little bit about your research because
sure.
some of your work is really interesting. From your perspective, you sort of gone to all this kind of basic science, translational research, so you see what's around the corner, right? Can you sort of pull away the curtain and share with the audiences like what's around the corner? What are some of the exciting thing that's going to happen?
Right, right. So, well, you mentioned our work, so I'll just very briefly mention that what our focus on is tumor biomarkers. So, basically, trying to identify patients who have a melanoma that's going to be more aggressive or less aggressive, and devise tools to help doctors manage those patients. And what we've been focused on mostly in the in recent years is circulating tumor DNA, which is DNA, and this is for basically patients with metastatic melanoma. The cancer cells die or they replicate so quickly that they have cell turnover, and they have small fragments of their DNA that has mutations in it, ends up in the bloodstream. And we're basically developing tests to monitor patients using that blood test to see, who's likely to do better or worse on their treatment. So and then hopefully we can get these tests into the clinic where doctors can actually use them, because right now there really are no blood tests for melanoma, in contrast to some other cancers where people follow the blood marker, for the cancer, and that helps them decide, what to do. For the metastatic melanoma patient, they go in for frequent CAT scans, and there's really no blood test, so we're hoping to develop a blood
And
test.
does this DNA marker that's circulating in your bloodstream apply to all type of metastatic melanoma, or is this a special variant or special, let's say BRAF mutation
Right,
positive, or is
right.
it doesn't really matter which BRAF status?
Right. So our approach has been find get a small piece of the tumor and look to see if that BRAF mutation is there, or another mutant is called NRAS, and then there's another gene called TERT, which is actually very frequently mutated in melanoma. So we have 7 different assays for mutations in these 3 genes, and our strategy has been choose one of those mutations, because BRAF and NRAS usually don't occur together. And if we can't find one or the other of those, we look for a TERT mutation, and then we have a test that we can use for that patient. It's almost like personalized medicine in a sense that it's, the test for the patient. And those 7 assays basically are found in a couple of studies that we've done, and just about 90% of melanoma patients will have one of those 7 mutations.
So
So
do you just step back a little bit. I'm
yeah.
just trying to think, how would you deploy this in the clinical setting? Do you actually have to analyze the tumor biopsy tissues to find out exactly like which one of the mutations that,
Yeah,
it
yeah,
has, and then you just basically measure that specific. Let's say if you have BRAF,
exactly.
you only look for BRAF, it's
That's right.
NRAS, but why not just do all seven?
Well, our approach. So there are companies that do that sort of thing,
Yeah,
and they do. It gets a bit technical, but they basically use a sequencing methodology.
yeah.
We use something called droplet digital PCR, which is a different kind of approach that's more sensitive at the molecule level, if you will. That's a technology that we've been, working on, and we think it has advantages because it is more sensitive at the individual molecule level, and it's much less expensive than the sequencing-based assays. So that's why we prefer that. We think that in the long run, if these assays can perform well, that payers are going to be more interested in paying for a less expensive assay, and also something that can be used to monitor the patient. So you might get this, a broader sequencing approach very early on in the patient's disease course, but it might be too expensive to check every 3 months or something like that. Whereas our test, we think, can be done on a more frequent basis because the cost will be less.
Do you worry about, let's say, one clone of cells, one clone of melanoma, let's say carry the BRAF, right? And that clone is eradicated.
Yeah,
but you have some other smaller clone like NRAS,
right.
even though they don't come or
Well, you're hitting
together.
on a great topic because that's another area of our interest, which is tumor heterogeneity.
Yeah,
And
exactly. That's the word.
yeah, so we and others have shown that this can happen. And one of the resistance mechanisms to BRAF targeted therapy is the emergence of
Yep,
NRAS mutant tumors. So it is something that we do think about. We haven't gotten there quite yet in terms of developing assays for those patients after the targeted therapy doesn't work. We do know that. We still see patients, BRAF mutant patients who the BRAF goes up after they've been treated with the BRAF targeted therapy. So the targeted therapy doesn't really eradicate all the clones of
for
the
sure,
BRAF
for
mutants.
sure.
Yeah.
I
So,
really
but it's
hope, I
yeah,
really hope this works because now you can avoid potential need for putting patient into this PET scan, CAT scan, getting them dose and high dose of like radiation, right?
yeah,
Um,
yeah. And then
I'm gonna,
also
okay,
yeah, and yeah. So
okay.
the last thing.
No, I think we're
Yeah.
running